Good afternoon. Hello and welcome to our event today. My name is Sydney Bell. I'm the program lead for the Ontario network of CAPC and CPNP projects. And we're really delighted to have you here for our Maternal Mental Health Awareness event. We're really excited about our program today. First, I want to just tell you a little bit about our network. Our network of CAPC and CPNP projects is a virtual network connecting over 175 projects across Ontario. And our role is to connect, inform, engage, and respond to projects in improving health and well-being of vulnerable children aged 0 to 6 and their families and communities. So as we come together today, I would like to invite us to pause and take some time to give gratitude and thanks to the land and to those who have been the traditional keepers and stewards, the first peoples of the territories where we work and serve. And we affirm that it is through the stewardship and sharing of the land that allows us to provide ongoing support to communities and vulnerable families across Ontario. So much gratitude and miigwech. Our agenda today, really quickly, we have our guest speaker, Vani Jain coming, and Blanca will introduce her, and she's going to talk about maternal mental health. And then we have some network members joining us on a discussion panel on maternal mental health promotion. So as you've heard, we are recording this gathering, and the recording will be shared with network members on WebConnects not too long after the event. So now I would like to introduce Blanca Serrano from the Public Health Agency of Canada, who's sort of co-hosting with me today, and she's going to introduce our guest speaker. So hello, Blanca.
Hi, thanks, Sydney. Hello, everybody, and welcome. And thank you so much for taking the time this afternoon to join us for this event. The Maternal Mental Health Awareness Day is celebrated around the world. This year was May 1st. And it's a time where, it's meant to come together just to pause and think about the reasons, why we have programs to support women, birthing people, and families around this issue of perinatal mental health. And of course, our groups do great work in mental health promotion and supporting women and birthing people across the province, across the country. And I think it's going to be about 10 years that this event started at a regional office in Ontario. We began wanting to showcase and highlight the work of CAPC CPNP when it came to perinatal mental health and maternal mental health. And at the time, because limitations with traveling and budgets, we had to keep it regional. So we try to always invite a guest speaker from our stakeholder community, as well as someone, a project that would bring awareness to the rest of our, stakeholders and teams in our regional office about the work of CAPC and CPNP. I think since 2020, during the pandemic, it was kind of silver lining that we were able to now join with the network and host this event and make it accessible so that we could all participate and celebrate together the work that we do. So it's just a little bit of context about today's celebration. We also over the years have tried to have it before Mother's Day so that, it kind of builds into that celebration and awareness. This year was a little bit different, but Sydney and I said, well, we're still going to do it. So I want to thank our panel that we'll be joining later and Vani for being our guest speaker today. And I'll just do a brief introduction of Vani. So Vani Jain is a dedicated and experienced leader with a passion for systems change. Throughout her work in medical education, mental health, corporate social responsibility, and philanthropy, the key thread in Vani's career is a true passion for meaningful, long-lasting social impact. Vani is the founding executive director of the Daymark Foundation, a philanthropic foundation that aims to transform mental health in two areas: women's mental health and bipolar disorder. Prior to this, Vani led the McConnell Foundation's mental health, well-being, and K-12 education portfolios. She has also held roles in communication, public policy, government relations, and program development. I'm really happy that you're able to join us, Vani, and share some of the work uh, and the expertise that Daymark Foundation has brought, as well as opportunities for others to provide insight and input into this important issue. So welcome, Vani.
Great. Thank you so much, Blanca. It's just been so great getting to know you over the past few years and having you input into our work. And it's really a pleasure to be here with you folks today. So maybe just to start off, I'll tell you a little bit about our foundation. So we've been around for about 3.5 years. So we're the family foundation of the Michael McCain family. As Blanca mentioned, we have two priority areas: women's mental health and bipolar disorder. And we made a decision early on to focus specifically on maternal or perinatal mental health for the first 10 years. We're a little bit different from other funders. We take quite a hands-on, proactive approach to understanding the issues that we're working on and identifying partners that are aligned with our goals. We take a systems change approach. So in addition to funding projects on the ground or work that's happening on the ground, we try to understand sort of the root causes of issues, what's happening, and the roles of different stakeholders. So that includes charitable organizations, it includes government and government programs like the ones that you folks work on. It includes professional associations. It includes maybe the private sector in some cases. So really trying to think outside the box about who is involved in creating the change that we're all seeking for, and also just impact at scale. So as a national organization and a national funder, we have limited ability to fund sort of local work. And so we're really looking for impact at scale and investments and partnerships and projects that will lead to that. And at the same time, just so appreciate the type of work that is done at the grassroots by programs like yours. So I'll in perinatal mental health, we have made 14 grants to date, totaling over $3 million. We've convened folks around different topics, including a stepped care approach to perinatal mental health. What does that look like? And really taking a holistic view that includes not just sort of formal supports in the health system or in the mental health system, but also informal supports, so the role of social networks, the role of awareness, in a step care approach. We have convened folks and launched some projects around access to doula care, in particular for queer, trans, and BIPOC communities. And Blanca attended our National Perinatal Mental Health Policy Symposium last November. We have had a sort of theory of change, and you can feel free to take a look on our website if you're interested in learning more, but a kind of theory of change that guides our work. And we're right now moving into a 5-year kind of action plan for advancing perinatal mental health. So really trying to nail down what are some big bets or some key priorities that would make a big difference on the perinatal mental health experience of Canadian families, and really trying to double down on those. So Blanca asked me to share some data that we had gathered. So, if we look at the existing data, population level data on perinatal mental health, it's fairly scarce. We are doing not a good job of collecting data on this issue at the point of care. And we've recently funded the Society of Obstetricians and Gynecologists of Canada to do an analysis of that. And so this survey that was done, believe it was 2018, 2019 on perinatal mental health, so pre-pandemic, by StatsCan, was sort of the best population level data that we had. And it kind of gives a bit of a picture around prevalence of postpartum depression and anxiety, but it's not really telling us anything about pregnancy. It's not telling us about other mental health issues outside of depression and anxiety. And it didn't kind of paint a holistic picture for us on what was really happening for perinatal people with regards to mental health. So we commissioned our own population level survey. So it was it was conducted by a survey panel. So it wasn't like a survey that we sent out that people could choose to take part in. It was done through kind of like an Ipsos Reid type survey panel. We had a representative sample of 600 mothers. We were pleased with the kind of spread in terms of having folks from different equity deserving groups and some good representation from across Canada. So although it was a small sample, it is considered to be representative in terms of what it's telling us about what's happening with perinatal people in Canada. And I'll just go through some of what we found out. So with regards to the perinatal, mental health during the perinatal period, so pregnancy and postpartum specifically, 1 year postpartum. So, the stat is about, 20 to 25% of women and birthing people will experience a perinatal mental illness. That is consistent with what we found, but we also found is that 2 out of 3, so 66% of mothers felt sad or anxious during pregnancy and postpartum. So what that tells us is that in addition to those who have a diagnosable mental illness, there's also a good chunk of women and birthing people who are struggling with their mental health and where there's a bigger prevention opportunity. So these are folks who maybe don't meet diagnostic criteria just yet, but are like in that risk category for whom, supports are definitely beneficial. We looked at burnout and feelings about sort of adjustment to parenthood. When we looked at mothers in general, so not limited to the perinatal period, 2/3 are concerned about their mental health, and of those, half are very concerned. So definitely a big topic for folks. We were able to separate that out and to see how these numbers were varied across populations. So looking at single mothers, who I will say overall in the sample, single mothers really stood out as having a much higher proportion of perinatal mental health issues. We saw some variation around income levels. Certainly BIPOC folks were more concerned about their mental health. And also I would say a standout group was mothers with a disability. When we look at risk and protective factors, you can see on the sort of risk side of things that, we have sort of over half of people felt fears about the future. I will say this is like a little bit compromised by the COVID pandemic and specific feelings that people had around that time. 1 in 5 experience lack of or instability around basic needs during pregnancy and postpartum. So that's a huge percentage if you look at population wide. 20%, 40% reported significant challenges with breastfeeding, which we know are correlated with mental health challenges. And then when we look at protective factors and feelings of having a support system, only 33% felt that they had a support system most of the time. 1 in 4 rarely or never connected with friends and family. So again, what we're seeing is sort of these non-medical kind of issues and what's happening for people. When we look at help-seeking behavior, less than half of those who felt very concerned about their mental health received some sort of support or treatment for their mental health issue. And this was really interesting for us. So when we asked people, did you receive support or not? And then for people who didn't, when we asked, why didn't you access support? Only 40% said that they didn't need it. So for more than half, they felt that they needed support but weren't able to access it. And I think this was really surprising in some ways for us, that stigma and awareness were bigger barriers than access to care. So either not knowing that they were actually dealing with a mental health issue, so they didn't know that they needed support, they didn't feel comfortable asking for it, it wasn't offered to them, they didn't know where to go. So just like not being able to kind of navigate the system, or feeling ashamed or stigmatized, not feeling like they can talk about this. There were also some access to care barriers around affordability, for example, for psychotherapy, wait lists, local availability and cultural safety, but I think it's really important to note how highly ranked these more kind of stigma and awareness barriers were. This is just an interesting one where we asked a question around how well informed you feel about the following topics, and we listed out a bunch, and awareness around strollers and cribs and other baby gear was very high, and awareness around mental health was very low comparatively. So when we think about the messages that pregnant and postpartum women and birthers are getting, the things that we're talking about, the things that we are, are sort of prioritizing in importance, mental health is really, really low. Very high percent of women agreed that they didn't know that they were experiencing mental health issues until they were able to look back retrospectively. And people don't actually necessarily believe or know that mental health issues during this time period are preventable and treatable. Doing a deeper dive into social determinants of health, we know that cost of housing and essentials, cost of living is rising, and it's a concern to most mothers, but definitely a percent that are very concerned. And mothers are more likely to be concerned about these things than other Canadians. Navigating around here. And then we see food security as well, issues around lack of access to nutritious food. And then when we look at equity, we definitely see reflected these huge disparities around race and ethnicity, so BIPOC mothers feeling much more concerned about their mental health, and also feeling huge levels of discrimination within the healthcare system. The good news is that when we asked people who did receive treatment whether they found it helpful, 95% of people did find it helpful. So I think this is a really good news story in that, I think I can talk about our bipolar disorder area where we can say, even the treatments are not good, right? Like people, even if you can access treatment, that doesn't necessarily mean that you are going to recover or improve. But in perinatal mental health, the supports and the treatments work, peer support works, psychotherapy works, medication works. And so we just need to make sure that people have access to those. So I will send around these slides, and you can, for those who didn't take notes, happy for you to have access to those. So I'll move along, and happy to go back into the data slides when we have a discussion. But the symposium that we held last year was fantastic. We showcased lots of different programs, including the Parkdale Queen West Community Health Centers, CAPC and CPNP programs, which was great. And I think some of the themes that came out of this was like, a big one was just like, we don't need more psychiatrists. Like, even the psychiatrist said, we don't need more psychiatrists. So there was a real kind of common feeling that over-reliance on psychiatry is creating huge bottlenecks, and that there's lots of supports that are really effective that we need to make more available and accessible to perinatal people. The social determinants of health are really significant, and medication alone is not going to solve this problem, and we need to make sure that we're meeting the basic needs of perinatal people. Communities know what they need. So it's just like so fantastic to hear about the work that's happening at the grassroots, how much expertise and passion exists at those grassroots, and just making sure that those organizations are resourced to do what they do best. The perinatal population is not homogenous. I think it's, the biopsychosocial model is very, very applicable to this issue area. There are some folks for whom, this is their concerns are related to their genetics or their hormones, and medication is what they need. There are others for whom it's more psychologically based, and CBT and other sort of psychological interventions to help them reframe their experiences, build their self-compassion, like that's what they need. And there are others for whom this is very socially driven, and what they need is social connection, or what they need is safety. And so we can't say like X solution or X intervention or X program is what everyone needs. It's not a homogenous population, and we need to make sure we have a variety of those supports. And then finally, we need better data. We need race-based data, absolutely. and connections are vital, and just improving field cohesion is really key. Coming out of this convening, we have embarked on a process to, as I said, develop this 5-year strategic plan. So we conducted a large-scale stakeholder survey where we heard from all kinds of folks, clinicians, researchers, people with lived experience, frontline workers, around, what are the principles for improving perinatal mental health. So at the bottom in yellow are some service principles, which are that they need to be culturally safe, they need to be accessible, trauma-informed, and timely. And then at a system level, we need a dyadic approach. So we need to acknowledge the inextricable link between mother and baby. We need to acknowledge the biopsychosocial model I just mentioned, stepped care. So we need to make sure that people are accessing the right levels of support based on their needs and preferences. And we need to go upstream and take a more preventative approach. In terms of the actual priority areas that we are looking at, so this is very much a work in progress. I'm just sharing at you a point in time. But this is sort of the 4 components that are sort of based on a user journey that we are looking at doubling down on. So one is meeting basic needs, which, I don't need to explain to you folks what that is. Building provider capacity. So just as, there's so many healthcare and related interactions during the perinatal period, and just making sure that those providers, whether they're perinatal providers or other primary care providers, have the knowledge and the tools to be able to assess mental health, notice what's happening, and to address them within their scope of practice. They also need to be able to refer folks to additional supports, whether those are clinical supports, community-based supports, or basic needs supports. So I think, I'll talk about it a little bit more later, but streamline referrals in a really comprehensive way, and then ensuring access to the support. So notably peer support and psychotherapy, making sure that those are available and accessible as kind of first-line interventions. Thinking about the role for CAPC and CPNP programs, definitely on the basic needs side, so impressed by the food security work that happens within the CPNP program. And it is so, so important. And we've heard so many stories of the stress that is related to food security, both during pregnancy and postpartum, and infant feeding issues, and just making sure that those needs are met. Violence, I didn't mention it in the data, but really almost 1 in 5 women have felt fear for their personal safety or security during pregnancy and postpartum, which is just a massive, massive number. And so, knowing who is at risk and making sure that they're supported. I think it's important when we are looking at building provider capacity that it's not simply, I think the wrong route would be to just train OBGYNs on how to prescribe antidepressants. I think we need to make sure that providers are aware of the social determinants of health and the link between perinatal mental health and child development. So for lactation consultants, for pediatricians, for even providers who are focused on baby, for them to be aware of the role of mother and the social determinants of health. And then when we look at those streamlined referrals, I was looking at the list of CAPC and CPNP programs, just how wonderful it would be if when providers were looking to make a referral, it wasn't just, I'm going to make you a referral to this, psychotherapy program or to this psychiatrist, but I'm going to make you a referral to this parenting class or to this breastfeeding support group or to these, this group or this program for mothers dealing with substance use. So just really leveraging and making accessible the full range of supports that exist in communities beyond just the kind of traditional clinical supports. So that is the end of my presentation. I hope that was helpful for folks, and I'm very happy to answer any questions or engage in a discussion.
Thank you so much, Vani. I'm glad you mentioned that the slides, you're happy to make those available. We did get a couple of questions about that. So, and I think I will maybe remove the spotlight here. And Yeah, open it up. Does anybody have any comments or questions for Vani and Maureen? Hello. Oh, you're not quite unmuted yet. No, we don't hear you. Oh, it looks like she's going to type. I'm going to ask to unmute, see if that helps you. Did something pop up there, Maureen?
There we go. I couldn't unmute without your permission.
Oh, there. Oh, right. We changed those permissions. Okay.
Vani, that was quite the presentation. The stats were shocking, to say the least. I just wondered if it would help too if, again, advertising our CAPC CPNP programs is imperative, I think, to get women linked to our program, and wondered if you'd consider putting a link to our programs on your website, because it shows a map of where they are right across Canada. And I thought that might be an idea, if that was something you would consider.
Yeah, I mean, absolutely. I think I couldn't agree with you more that that making these services easier to find. We actually are, as part of our work in this area, are looking at potentially setting up a more kind of central website on perinatal mental health and potentially an alliance. So we're a foundation, so we're not really sort of the place where people are going to find services, but I think definitely increasing awareness of those services, having kind of public facing like a hub or some sort of like a resource place where it's just easier for people to find. And I completely agree that those need to be
Perfect. Thank you.
Yeah. We are on social media though. I can't say we have a very big following, but if ever folks want to follow us or tag us, we're always happy to like repost and send around.
Great.
Thanks for the question, Maureen. Anybody else have a question or comment for Vani? Ellen.
Hi, Vani. Thanks so much for that. I have a question. You said that your organization has supported 14 different projects over the past couple of years, up to with a total of about 3 million, correct? What kind of projects are these? And are these things that would be useful for us to know about to refer our families or our moms who are struggling? Because I feel like that's one of the biggest barriers is the resources for moms that are experiencing any type of problem.
Yeah. Great question. So we have funded a very wide range of projects. So I'll just give you some examples. So one is we funded the Canadian Perinatal Mental Health Collaborative to do some advocacy work. We have funded the Society of Obstetricians and Gynecologists of Canada to develop clinical guidelines for perinatal mental health that will inform the practice of OBGYNs, midwives, and family doctors. We've funded an organization that's recently rebranded. It used to be called Mommy Monitor. It's MenoCare, and it's a Black maternal health organization. So mental health is one of their areas. But there's also lots of others. We've funded a pilot of a perinatal psychiatry access program in the Ottawa region. So that's a service for providers where they educate and train providers, and they also operate like an on-the-spot phone and text line. So it's meant to decrease referrals. So rather than like referring your patient to a psychiatrist, you can actually just like call or text a psychiatrist on the spot, and you can learn how to treat them. And there's a sort of navigator. So we're all over we've funded Life of the Baby to do, to sort of work on their strategy around peer support and other sort of community-based interventions. So we are all over the place. Again, I would say, our grants don't represent the sort of universe of what supports are available. And I think it goes back to, I think there does need to be a place where you can go and easily find, like, I am struggling with my mental health, or my client or my program participant is, and where can we go? And I think that's definitely where we're going with that sort of like referral database, something that is both provider facing, but also user facing, where it's just like really easy to be able to understand, I think, what type of support you need and where can you go to get it. So, you know, definitely moving in that direction.
Thanks, Ellen. Any other thoughts or comments or questions for Vani before we wrap up this part of the event and move on to our panel discussion? Okay.
Great.
Vani, thank you so much.
Thank
Really-
you. I'll send you the slides now.
Okay.
So you have them, and it's, you know, it was a pleasure to be here, and just thank you so much for all of the work that you folks are doing. It's always a pleasure to visit those programs and see them firsthand, and it's just fantastic work. So thank you for everything.
You're welcome. I can
Thanks,
see
Vani.
the
Thank you.
information that you provided and really, you know, looking for opportunities to dig into it and inform our work. So that's really fantastic. Thanks, Vani.
Great. Take care, everyone. Bye-bye.
Bye.
Bye. Okay, well now what we've got planned is a panel discussion, and we've had some wonderful members of our network come forward and be willing to, you know, lead us off in this conversation around promotion of maternal mental health in our CAPC and CPNP program. So I want to welcome, along with Blanca, who's be joining us for this conversation. We have Ellen Bachtold is here, and from Southwest Zone, and Maureen Hampton is here from the East Zone, and Iman Ing is here as well, I believe from Central Zone, but she can let us know that. Because I would really like to invite you all to start off with an introduction. Tell us a little bit about yourself, where you're from and your project, and get to know you a little bit. Why don't we start with Iman? Hello.
Hi, Iman.
Thank you. I'm Yiman. I'm a health promoter with the Parkdale Queen West Community Health Center. And at the Queen West site, we do have a CPNP program we call the Great Start Together Perinatal Program. In short, we call the GST. So it's easy to remember, it's a tax. So within this program, we are very lucky. We are located within the health center. So in terms of access, like, to seek medical help for those who live in our catchment is very easy. And aside from the support material we provide clients, like, you know, the gift cards and things like that, we also have another program called the Feeding Tiny Soul, in which we will provide baby bundles a month before the clients give birth, as well as they have access to the LC a month before they are giving birth. So, it is very comprehensive, and later on I'll talk about the settlement services within the program, because in Toronto we receive majority of the immigrants within Ontario. So we end up, like, with GST, more than 90% of our participants, they are not born in Canada.
Right. Thank you for that. Really glad to have you here.
Thank you.
Ellen, would you like to say hello and introduce yourself?
Sure. I'm Ellen Bachtold. I'm from the Windsor CPNP program, Building Blocks for Better Babies. I've been around for a million years doing CPNP since the beginning of time. I've been here. I'm passionate about it. I love helping women. I love coming after a project that has given away $3 million in the past couple of years, because it really makes me think about the grassroots nature of what we're doing and how we have these little bits of money, and we are doing some great things out there helping moms and women. I have a passion for mental health. Maureen and I took the maternal mental health toolkit training in 2013, 11 years ago. And ever since then, I just make it kind of a high priority in our project to talk about it, to recognize it. And I think our main goal here when it comes to maternal mental health is to really try to normalize that conversation and to also be realistic with moms and to support them and recognize that not every single moment of motherhood is that magical moment we think it's going to be. And there are some tough times. And we need to, make sure that they know that we know that what they're doing is a lot of work, and it is very much appreciated, even though it doesn't always feel appreciated. So that's where I come from.
Thank you. And finally, Maureen. Hello, Maureen.
Hi, everybody. Welcome. Thank you for having me here today. And yes, Ellen and I go way back. Can't believe that training was in 2013. And that is a really great toolkit. And we can maybe speak to more of that after if people have questions about it. I have been with the CAPC CPNP program for 23 years now, called Connections, and we are located just outside of Ottawa in Lanark County with our main space in Carleton Place. I've worked in CPNP for 15 years, and then I switched over for the last 13 years, and I've been doing volunteer birth companion program, and I work as a parent educator for a group called Connections that many of you maybe have heard of from Breaking the Cycle in Toronto. We call it Making the Connection just because it's the same name, and we have great success on that, working with mom around her mental health and especially around the domestic violence. I think our guest speaker touched on 1 out of 5 women experience some form of abuse during pregnancy or as a mother. I think it's actually higher than that, and it's because it does not get discussed often. Abuse often starts in pregnancy or during pregnancy, and those women really don't understand it and why has it suddenly happened, and they go inward instead of outward and tend to blame themselves or make changes so that they don't even talk about it with anyone because they really feel that it's up to them to fix this. So I think those numbers are low, and we know they're higher, especially with young mothers, which our projects work with. So keeping that in mind too. Yeah, mental health for mothers is an important topic for all of us. I think if we're doing this work, it's imperative that we're thinking about this, and it's we have to debunk that myth, like Ellen said, that we're all happy and pregnancy is wonderful, and that I think it's important to recognize that the impact potentially on the unborn child and the child's development when they are born, it can be significant, and for the mom too, and for the rest of the family. So yeah, I think it's an important discussion, and I think as workers, we need to keep pushing for more education on this topic and advocating for families to have services that are specific to perinatal mental health, because we have a fair number of programs we can refer to, but it's overall mental health. It's, for people that may be experiencing bipolar or people that may be experiencing, but perinatal mental health is separate. And I think we need to take a special focus on that in order to serve that population successfully. So, but yeah, thank you for having me. And it's great that maybe we can get more people to come on screen and take part in the discussion. That would be great. Because it's an important topic.
For sure. I forget, Blanca, were you or I going to go first?
I can go first. We have, I think 4 questions just to get us started with the discussion. But of course, if others, want to pipe in and have other comments or questions, please go ahead. Our first question is, how does your project bring a mental health promotion focus into the work you do? So I don't know who wants to get started.
Why don't
Me?
sorry.
Sure. Yeah, I can do it. I think it's an overall in all of our programs. So we have 2 sets of programs. We have prenatal and postnatal. We have a prenatal drop-in program, which is called Good Food for Healthy Baby. And during this group, we do parent education with pregnant women and their partners if they attend. And we talk about risks of postpartum depression. We talk about, just basically we ask those questions. How are you feeling? Did you know that this many women experience some form of postpartum depression? We also kind of try to explain the difference between the baby blues and actual diagnosis of a person of like a mental health disorder. So because I had looked up today and it was saying that most women, 15 to 85% of pregnant women or after their baby are born do suffer some form of baby blues, which might mean a low mood or tearful or fatigued, but it doesn't last. So we try to talk about the differences between that and actual disorder that they would need to have support for. We have a birth companion program. So for high-risk women who are particularly at risk of mental health problems, could be young mothers, could be newcomers, could be women that are living with domestic violence, could be sexual minority women. So we try to match them with a birth companion so that this is a special support. It's a volunteer position, but a volunteer will support them through their prenatal period and in through the labor delivery and up to 6 weeks with some extensions in the postpartum period if they need it. So that's been a really successful program, and it helps because they will talk about mental health with them, and we've trained them to ask those questions because that's the key, right? And then after we have play groups for moms so they can bring their babies, and they also have discussions at play groups around this kind of topic. And we have family home support workers who will have those kind of conversations if they have any risk factors, and we'd always do an assessment for our risk factors. And we also have education groups too. So we have the Making the Connection group. We have we have a high risk group for mothers who have children in care or potentially will end up in care. So we work with them around supporting their children, and we spend a lot of time there talking about how that can be draining. So I think we do it in all of our programs. Like I think all the CAPC, CPNP somehow incorporate this kind of work. Yeah.
Great, thank you, Maureen. I think that was really great from Vani's slides, how one of the key protective factors was having social supports and networks. Yeah, I think it's one of the great things that CAPC CPNP provides.
Absolutely.
I can add to that. So we, prior to doing the Mother's Mental Health Toolkit, I was not super confident talking about mental health with moms or with families. And a really great way when you're not confident is you just don't ask them. So you don't ask, they don't tell, and everybody's happy. And after doing the Maternal Mental Health Toolkit, we made it a priority to talk to every mom on their first visit, asking them about their experiences with low mood, anxiety, depression in the past. And that opened that conversation. And that's that first time we can talk to them about it. We found that almost 50% of moms that are in our program on their very first visit with us, they're disclosing that they have had some type of low mood or they've struggled with mental health in the past. We were amazed by that. We couldn't believe it. We thought nobody's ever going to tell us anything. Why would they tell us? Because we came from the times when you didn't talk about mental health when you were pregnant or postpartum. So we we thought this is great. So now what do we do with that information? Uh-oh, now I have to do something with that. So we started doing classes. And so we included mental health. We call it Life as a New Mom class. We do it prenatally, and we used a lot of the tools that were in the toolkit. And that's in our rotation of classes. And then we realized, but what if they miss that class? So they're not going to get it for another 3 months. So we might have, missed out talking about it. So we decided to develop some small little mini classes, and we call those our mental health minutes. And we kind of slip those in here and there. We could be talking about introducing solid foods, and we might do a little activity around self-care, or something that would just be a little 5-minute thing, so that we're talking about it all the time. And we just have a variety of activities that we try to use all the time to make sure that we're talking about it, so they will be talking about it. And we talk about, one of the things that Vani mentioned as well is that people didn't recognize that they were they were struggling with their mental health till far after. And we realized that too. Moms would say, I think I did have postpartum depression with my second child, but I didn't realize it until far after. So that's what we thought. We need to prepare them prenatally for this, and talk to your husbands and your sisters and your family that are around you about this, and watching for that. So we talk about it literally all the time. We talk about self-care, so every day there's it could be every day, not necessarily, but we do talk about it at majority of our classes. We slip it in.
Great. And Yvonne?
Oh,
Oh,
you're still muted.
Sorry, talking to myself. So I'm going to talk about the settlement services. So what does it got to do with mental health promotion? So basically, for a lot of pregnant women, even though whether this is the first or second time, they worry about, am I going to have a healthy pregnancy, and my baby is going to be healthy, like these kind of things. But for newcomers to Canada, they have an other set of issues to worry about. So like, how am I going to communicate with my health providers? That is hugely depends on their English proficiency level. Even though if they have good English proficiency, but still it is a medical terms that they have to learn. It's not your daily language that you're using all the time. And so accessing or navigating the health system is different from their home countries. Different cultural practices, all these will impact on their mental health. And the more stressed they are, the more anxiety they have, is going to impact on their pregnancy and the delivery. So basically, settlement is a health issue, because once they come to Canada, it will impact, depending on their pre-migration and migration experiences, it will impact on their social, economic, health, and political areas. So basically, GST has been very lucky since 2008. We have been in community partnership with the neighborhood group. The former name is St. Stephen's Community House, as well as Scadencourt. And we were so lucky to have a team of 7 workers to work with our program, because as I mentioned before, 90% of our participants, they are newcomers to Canada. So, so aside from the settlement team, and even within the Parkdale Queen West staff, we have staff who speak Portuguese, Spanish, Chinese, and now we do have Ukrainian staff because of the regional conflicts. And so basically, if they can speak the common language, they can build a rapport a lot more easier, and they are more readily to talk about the issues that they are facing. And the settlement workers, they have an edge over this, because once they come to Canada, there is they will do a lot of information and referral. And first of all, they will do a needs assessment. So in terms of what kind of how are there any housing needs, employment, isolation, like these kind of things, because like, once you come to Canada, pending you might be separated from your families, and you're here all on your own, not just only like taking care of yourself and your baby in the future, but in terms of finding out information about living in Canada. So that is not easy. So it's a lot more work for them to do. So with settlement workers, they can help them to talk about like access to medical services, housings, and also in terms of like applying for social benefits and baby documents. So they don't really have to worry about all these things. So there will be help available for them. So which means they have more time, and hope that this will have a better mental state to take care of themselves during the pregnancy. So we also, depending on what is happening in the world at this point in time. For example, we 30% of our participants right now, they are from Ukraine. And because of what is happening to them, we do, aside from the weekly webinar that we have, we also hold webinars outside our regular program for this group of people. And we talk about like immigration and also mental health on PTSD, like these kind of things, because I remember when we did one session with our in-house counselor, and afterward, several people accessed the counseling program. So, which is really nice to see that, because, they really recognize like the issues that they are going through, and which is not going to be healthy for their pregnancy and things like that. And then they see that like their service available for them to access like these kind of things. And also at the programming level, I mean, the weekly webinar, we do offer Mandarin interpretations, so they don't have to worry about, oh, I don't understand this, what is happening, because 40% of our clients, they speak Mandarins. And because of the influx of the Ukrainian participants, we also have a program support worker who speaks Ukrainian, and she will do the translation in the chat box. And that really helped them greatly to, to learn about different things like pre and postnatal health, as well as settlement topics and mental health issues, like these kind of things. And also, since the settlement worker, is working with them a lot of the time, they will understand what kind of issues that they are facing. And then, we will have a meeting together to see, okay, what kind of topic we should have in the near future to address all these things. So, so we try to address everything, like, at the individual level, at the program level, as well as the community level as well. Coming to Canada, sometimes, a lot of the time, I would say they are not aware of their rights. And especially patients' rights. It's very different. So in the past year, just the past year, I did write at least a couple of complaint letters to health providers about that our clients are being mistreated. Like, they talk about it, and then it's like, wow, what, is it okay? Like, you need to let them know that they violate your rights as a patient. And a lot of times, well, no, I don't want to get in trouble. No, you're not. So there is another level of like, letting them know it's okay to do that. And you know what? And I will be with you even after the letter is sent out and the follow-up. You don't want to leave them high and dry. It's like, okay, the letter sent in, and they call them. But it's happening, like, it's even more stressful. So like these kinds of things are very important for them. So so we do address everything at different levels.
Thank you.
Thank you. That's our great activities and supports for sure.
Definitely. Our next question that we had for our panelists was about mental health promotion resources that they draw on. And certainly you've all mentioned some already, and the Mother's Mental Health Toolkit has been referenced more than once. And I see Blanca put the link in the chat that can, oh no, that was a different, I'll put the link in the chat for the toolkit. But certainly, so that is, you may have others, or maybe talk a little bit more about the toolkit in terms of particular ways that you use it. But I wonder if, actually, Iman, could we just stick with you around this question? Do you have particular mental health promotion resources that you draw on? Is there anything you wanted to share with that one?
So basically, we don't have a particular one, but like we are very thankful that Blanca has been sending all the resources in an ongoing basis, and certainly they are very helpful and broaden our perspective in providing services for the participant. I mean, GST has incorporated the integrated settlement services to promote mental health within the social determinants of health framework. But like it's always helped to have updated information, new information to help us to go along. But then on the other hand, as I'm saying, partnership is very important. So like we draw on the resources of our existing partnership as well, like the formal ones. And we share the informations on how to do things better for our participant. But not just only that, but we also have informal relationship with other service providers, such as like, with the midwives, and because like a lot of things has changed since COVID with Toronto Public Health. So the connection has kind of lost, I would say. So we have to draw on some other resources to update our information, our skills, and things like that. So this is what we have been doing all along in a very informal ways. So because like, depending on who is coming to Canada, again, it's the global geopolitics. You always have to provide services in a very different way. So, and COVID is a very good example in terms of like, I can never imagine that like, we'll be doing webinars and things like that, or hybrid. So like these kind of things in terms of service provision, we provide like one-on-one support, in person, over the phone, and over Zoom. So it's their choice. But then sometimes we have to be very careful in providing support over the phone or Zoom, because especially on intimate partners violence, you don't know who is behind the camera, you don't know who is behind the phone. So in terms of that, like we are learning a lot in terms of like from other resources material on how to deal with these kind of urgent issues.
Thank you, Iman. Ellen, do you have anything to add around resources that you draw on?
Well, you've heard of the Maternal Mental Health Toolkit. So we do use
Yes,
that.
that's true.
But I think what that does is that inspired us to take some of those activities. It's not very often that I'm going to photocopy something and just use it directly out of there, but it does help me to, or us, to create activities that work within our group activities. We're not doing one-on-one stuff, and a lot of those activities are more meant for one-on-one. So we've created a class that uses those concepts and then, but does it in a class setting where women are allowed to share. And I think that is where we're really finding it's very important to have that interaction, that interactive kind of activity, because when one mom says something, then another mom will say something. I asked my group this morning, I was in a group with low German speaking Mennonite women, and I said, ladies, I gotta do this thing this afternoon. Like, what would you say? Like, why do you come here? What do we do for you here? And one of the things that they said was, it's just good to be in a room with other women and talk to them and know that some of the stuff I'm experiencing that I'm stressed out about, other moms are experiencing that as well. And not that it makes it better, but it just makes it feel a little bit more normal, right? It doesn't make you feel odd or that you're not coping as a mom. It's happening to a lot of moms. So I thought that that was like one of the questions that you gave to us, Sydney, was what are we doing? Why can we do it? And it's women coming together. And I think that as far as the resources that we're sort of utilizing is those opportunities to get moms to talk about stuff together, and so that they're helping each other. And that's kind of the approach we take in our group classes.
Thanks, Ellen. Maureen.
Yeah, so I sent Sydney a link to you earlier today, is a book that we use from Public Health Agency of Canada to hand out to women, and especially if we're doing a topic on mental health or something like that. I'd also wanted just to, you know, most of you probably already consider this, so if I'm preaching to the choir, I apologize, but you know, since we all know, since COVID, many more people have endured mental health disorders. And I think COVID isn't over yet, and in that sense, and I think we really want to make sure that we're you know, assessing first who might, and we know like new immigrants, and that I'd love to learn more from you, and because we have so much to learn about how to support new immigrants, and I think it'd be great if you could do a training for all of us. But we know that newcomers are a risk for postpartum depression. So, you know, we want to make sure that we're assessing people. So for us, we look at people that have previous mental health disorders. We look at people with childhood trauma, poor social support, and also considering women who have had traumatic births. That's something we really need to be aware of, that women that go through traumatic birth, they may appear great, but they, even toward the end of the 12-month period postnatally, they could be going into a depression, and we may not be assessing for that anymore. So it's really important to assess throughout that whole first year, right to the very end. And also for women who have children that remain in hospital for issues around substance use or you know, heart defects, whatever might that problem be that a child has to stay. Those moms in particular too are at risk. Those that are having, you know, stressful life events, living in poverty or domestic violence, like we discussed, but Indigenous women, young women, recent immigrants, sexual minority women, and also young girls that appear that may have anorexia or bulimia or some form of eating disorder. I don't know about you, but we deal with this a lot, and sometimes it's hard to pinpoint. And but having those uncomfortable discussions, and this is where again that mental health toolkit comes in. And if people aren't familiar with it, we did do a training before on how to use the kit, and you can access that on WebConnects, right? And if someone would like an actual hard copy of the book, contact me and I'll send you one, because there's things in there like self-care charts. So you would work with a woman and you can say, you know, is nutrition something good for you? Oh, I'm not a big eater, or oh, I feel a lot of nausea, so I don't eat very much. Those are all cues that we may have to work. Assessing for smoking, for a mom that is like a high smoker, over a pack a day, you know, because they are potentially having a higher risk of a lower birth weight baby, that higher their risk for postpartum depression after the baby is born, to have a low birth weight baby come home or have to stay in hospital. So I think that pre-assessment while they're pregnant is really an indicator for us to, okay, this one may need a little bit more attention. And that postpartum book from Public Health is good, or Public Health Agency of Canada. I know our public health unit has resources online, and we try to work in partnership with them. And also just asking women, would you like a referral to a counselor? And do your own homework. Which counselor is comfortable talking about postpartum depression? So when you make a referral to like a free counseling service, you can ask, is there anyone who specializes in postpartum depression? Or is there anyone that's more comfortable talking about that or that kind of thing? So, and same with if you're working with a woman who is that you believe is in a domestic violence relationship, find out if there's a place, is there a women's shelter that you could send her to first to get a safety plan under place, to like someone mentioned, I think Ellen and all of our speakers have said, you know, those basic needs need to be met first before we can start addressing mental health disorders, right? So yeah, and the toolkit is really great because it can help us enter into those tough conversations that you may feel uncomfortable with. So I think that's why we love it so much, Ellen and I, because we incorporate it in all our parent education groups. Every week women go home with those sheets, or we do the sheets together in person, and they can all lead to the question, are you experiencing postpartum depression? And even just depression, because sometimes women are afraid of that label, postpartum depression. We can even just say, are you feeling depressed? Are you feeling anxious? Do you have insomnia? How do you feel about your baby? Because women feel shame when they don't feel attachment to their child, or when they feel they shouldn't be depressed. You know, I really think we have to remember that because we picture it like it's this beautiful bubble of happiness, and for most women it is not. And women are still doing the majority of labor in the home. Even if there's a dad in the house or a partner in the house, women are still doing the majority of the work. And that we need to consider that, because, you know, and if a woman has twins or a low birth weight baby or colicky baby, you know, I don't know. I just think, you know, there's so many women that are potentially, that we work with, at risk for this. So, yeah. So, and just keep asking, and if people aren't comfortable with these kind of questions, seek out training so that you can become comfortable, because it can be life-changing for those women.
Maureen, you bring up a great point that somebody messaged me just, you know, some comments that I've heard before, right? In terms of often maybe the fear or trepidation that we might feel in opening up conversations around mental health promotion, because we feel we're not mental health professionals in a certain way, right? We're not psychotherapists necessarily, or you know, so do we have, you know, are we qualified to be talking about mental health? And I think one thing it brings up is perhaps that distinction between mental health promotion versus offering therapy is one. And maybe recognizing that, you know, we do have specific opportunities. You mentioned the Building Connections program, which offers a particular training to hold particular conversations. So actually, you know, if any of our panelists or anybody else here present has any thoughts or comments on that, on how we sort of navigate that feeling of, I can't even mention mental health at all, or invite people to consider their mental health if I don't have a certain, you know, degree or mental health training.
If I could just add one little thing, and then I'll let other people speak. I think we know the difference between therapy and conversations. So, you know, kind of look at it that, like, I'm not a therapist and I'm not going to diagnose anyone or even suggest to somebody, I think you have postpartum depression. I would, if you're just opening up the conversation so that we can refer, and if they're open to referral. So I think, you know, it doesn't have to be, oh, do I know what I'm talking about? If you can if you can tell them 4 or 5 symptoms of what depression may or may not look like, you've opened up that discussion. So I really, because you're the people that they're going to come to. We're the people that they're going to talk to first, because they don't necessarily talk to their doctors right away, because they have that fear of stigma of, I'm a terrible mother because I'm not really happy, right? So go ahead, sorry.
I was going to say the same thing as Maureen had mentioned too. It's just a matter of having open conversations, validating emotions, and not providing a diagnosis. It's just providing evidence-based research or resources that we have on hand to give to our participants, rather than an actual diagnosis, so to speak.
Thank you, Sherry. Rosalind, then Iman.
Yeah, I was just going to say, you know, what we hear from one of the mental health agencies we deal with is that they would never connect with our families if it wasn't for CAPC and CPNP. So I think we are so often that bridge to mental health supports and other supports in community. And because they trust us and we have the relationships with them, it's a great point of departure that just might not happen otherwise, because often they don't have the self-advocacy skills yet, or that sort of confidence to reach out on their own behalf, or they've had problematic experiences with other agencies. So you kind of made that comment at the end of your remarks, but I just wanted to note that because it is a balancing act for sure. And I think you're right, Sydney. It's just sort of that balance between promotion and understanding what our role is, the scope of our role. But those connections, I don't think can be underestimated for sure.
Sure.
Thanks.
Thanks, Rosalind.
Yep.
Iman?
Thank you. I really like the way Rosalind just talk about being the bridge, and a lot of the time we are the bridge, like connecting of the participants to the services that they need. And it is very difficult to talk about mental health issues and things like that. Really, like, depending on the culture that they are from, it could be a big time taboo, stigmatization, like these kind of things. And, a lot of time we're just like, oh, would you like to talk to someone? It seems like you have a lot on your mind. So you'd like to talk to someone and see how and then you can start it from there. And I think a lot of the time, they may feel that, oh, okay, if I talk to a counselor or something like that, will somebody know about it? We always make it clear to them, like, in terms of privacy and confidentiality. So this way, it really put their mind at ease. Okay, so that will be just between me and the counselor and Eman, like these kind of all three. We'll just know it. Other people won't know it. And I'll let them know, you know what, your husband cannot even get any information from us, or your partners or your family, like these kind of things. So this is an important thing because a lot of the time, depending on where they're coming from, like, the husband can call the doctor, okay, so what is going on with my wife? And the doctor will tell him. So, and sometimes it's very interesting. We do have a participant, you know what, yes, no, I don't mind talking to a counselor, but I don't want to talk to somebody from my own communities. You see what I'm talking about? So they're very mindful about that. So that's why it's so important to get that permission from them before you do the referral and make sure they understand what is that all about, what counseling means in Canada. Because, like, it means different things in different countries.
Very important. Thank you for that, Iman. I saw Ellen and then Belinda.
Mine's very quick. I just want to remind people to ask them, because 90% of women will not bring it up until you ask. And then they will disclose these things. But it's that having that confidence that we all have to just say, how are you feeling? Like, your baby's adorable. A lot of times, we're so focused on the baby and the weight of the baby and the breastfeeding of the baby, but ask mom how she's feeling, and not just physically, write out, come out and say, did you have any of those baby blues we talked about? 4 out of 5 moms are going to have that. So actually, if you didn't have it, you're actually the odd one that didn't. Almost everyone has it. So did you have any of that? And how are you feeling now? So we just have to have that confidence to open the conversation with them. And that would be my biggest suggestion.
Thank you. Belinda. Oh, no, you were unmuted. No,
Okay, sorry. Hi, thank you. This is such a rich discussion. Thank you so much to all the panelists. And to your point, Ellen, I just wanted to add, and it was very quick too, that I used to do work with like substance use and smoking and pregnant people. And I'm sure with all the other health units out there, Hamilton's public health unit, we're expected to ask, and we're not all comfortable with it. Mostly it comes from our own discomfort, but about substance use, about smoking. And we sort of got past that. It was a hard a hard pill to swallow and a hard thing to sell for most of us. But I think along that line and along that vein, they're expecting us as a healthcare provider, as a support person, that they often, sometimes the only people they see in their days, to bring it up and to open up to them. So most often, I think it's our own discomfort, right, with it. So it takes some counseling for ourselves. It takes our own recognition, I guess, of our own biases, reflecting, and what makes us comfortable and how to ask, I guess, is what I'm saying. Often you ask and they will tell. It just, yeah. I found that there's a lot of sharing that goes on, and especially at our CPNP sites, it's such a safe place for a lot of them. They have such a sisterhood, and a group that they feel so supported in, that they, yeah, it's almost like they're waiting for that moment. Yeah. That's all. That's all.
One more, Maureen, and then Blanca and I will confer about how we're going to wrap things up. Maureen.
Yeah, I just wanted to say, like a lot of places that we work that we refer to, they don't take referrals from us. A woman has to call herself. So we try to make, or I may try to make a practice of offering to call with the woman or take the woman to the appointment if we can. Some agencies can do that, some can't, or I get a volunteer for them that will take them to the appointment. So that can really bridge that uncomfortableness of, let's make the call together. And then then you can send out a reminder to, don't forget your appointment's Friday. Do you have a ride there, or help them get transportation there? I just think anything we can do to not rescue them, but to, help along the way to get them to that first appointment, it can make a big difference.
Absolutely. Yes, thank you. Again, I agree. This has been very rich discussion. I'm seeing we have promised we won't go beyond 4:30. I think we need to have a hard stop then. And my suggestion, Blanca, I wonder if we should go to the last question, because I think we've been talking about, the next question was about challenges. And I think this was a good example of that. So I'm thinking maybe ending on a positive note. What do you think?
That sounds good. I was thinking that too.
Do you want to add
it? Sure.
Sure.
Thank you for sharing all your insights and experiences. It's really valuable, and what a great discussion. It just think we need more opportunities to do this more often. So this final question, how are CAPC CPNP projects well suited to promote mental well-being? Who wants to go? Ellen?
Sure. I just think that we are that grassroots location, and we work with families for so long that we really do become that trusted person, that trusted face. And we have the same people week after week, like the same staff, and they develop those relationships with us that really lend to disclosing stuff about this. And I think that it's women helping women is another thing. And I think that one of the tougher parts is now with doing the virtual, like with hybrid programming, it's more difficult to develop those really rich relationships with that black screen, or, they're not sharing quite the same way as the in-person programs. So when we can encourage them to come in person, it's amazing. They will say, oh my goodness, this is so much more than what we get. The information virtually, but we don't develop the relationships virtually. So I think that we have that opportunity. We also are lucky in that we provide them we talked about those basic determinants of health by providing those $10 food vouchers and those vitamins. That's the draw to get them there, but that can help to alleviate some of that mental health stress. If it could be more, it would help even more. We all know that. But the resources that we have, those small resources and that dedication that we have, I think that's why CAPC and CPNP are so successful with all of this.
Thank you. Yeah. Iman?
Um, Definitely. I mean, the CPNP project is well suited to promote mental health because, like, you know, for those who get to our program, this will be the first point of contact, bringing them together. And also, the program provides a lot of, like, you know, education on pre and postnatal care and all of these things and settlement topics. You know, knowledge is power, and also with that knowledge, they can make informed decisions. And that will help them to ease a lot of the anxiety and, you know, wariness, and then moving on. Like these, I'm not saying that it will take away all the anxiety. I mean, it will always be there, but with the information that is very important. And also, because of the perinatal program, they will be getting like a wellness call on a regular basis. And we also like can do it like over the phone, or and in terms of picking up the grocery gift cards, we insist that they come to the agency to pick it up, so we have, you know, a chance to meet with them and talk to them. And certainly that helps to build relationship. But of course, it's very different from like an on-site program. That's the thing. But what I really want to say that the settlement services it is extremely important in terms of mental health promotion, because what we have is not your regular settlement services. It's a very specialized settlement services that we're providing. I can give you one example. For example, if I call a regular settlement agency on applying for maternity benefit, they'll give me the information, that's about it. But then the thing is, if they are in the program, we'll also provide them information, but we'll also ask them, oh, well, what kind of work do you do? Does that involve a lot of standing up? Do you have to move things? Do you have time to sit down if you're a waitress? And how does that going to impact on your pregnancy, like these kind of things? So these are the extra things that we are providing as a very unique settlement services.
Thank you. And Maureen?
I think real help right here, right now. You know, that is what CAPC CPNP is about. And you know, we're lucky because we get to step out of the box of like, unlike other agencies sometimes. So I remember talking to a woman, I was just trying to think what it was about, but I remember saying, how come now? And she said, because no one ever asked me before. And that really sat with me, and that was many years ago. So you know, sometimes just asking a direct question and not being afraid, even just like, you know, are you feeling sad at all? Or, you know, do you have any anxiety about the baby coming? And then it can come out. So you could word it in a different way. So I think we just have to keep doing the work we do and keep getting trained and reach out to agencies that we refer to and talk about, do you know what we do? Make sure that our programs are being promoted as best as they can, because I think we're the hidden gem right across Canada. I really do. And just promoting our own programs so that they know where to refer women to too, because we can make a difference in the life of a woman dealing with postpartum depression, even though we're not therapists per se, right? So I think we just have to keep promoting our programs because they work. We know they work.
Thank you. Excellent. Oh, we have Amanda has her hand up.
I was just going to say we're currently doing a hybrid programming, so we have virtual and in person. So today we had 35 participants on with us. And so we have different community partners that join those programs as well, like counseling services. And we do a check-in at the beginning of program just to see how the moms, and we have a couple dads that are now joining us, how they're doing, you know, and that seems to bring the group really closer together. So we found that helpful.
That's excellent. Thank you for sharing that.
You know,
Amanda, can I just ask what kind of questions you ask in your check-in?
Anything, you know, sometimes we even just ask them like how their weekend was, you know, how they're feeling. Sometimes we ask them, you know, if their little one has done anything that makes them proud. Sometimes we have so we have virtual every week, and our participants usually join us every week, and we'll take one program a month just kind of to do a check-in with them to see, you know, to see how they're feeling. And we found, so it's a requirement to have the cameras on unless there's special circumstances, like they have to breastfeed or that, then they're able to turn their camera off. So of those 35, all of them had their cameras on today. Yeah.
We really kind of, as of January, got more strict about cameras on, and kind of issued, again, very clear virtual guidelines and expectations. And we've seen a bit of a ripple effect as people start to turn cameras on and feel more comfortable. More people are turning cameras on because we've been pretty forgiving, understanding. Certainly our health unit colleagues expressed what someone said earlier, like if their cameras aren't on, we don't know what's going on. We don't know about their safety. So they were having the same challenges and other work they were doing. So they definitely supported us, and it's certainly been a challenge for frontline staff. But Amanda and our mother care team, which is our CPNP program, have done a great job. And it's amazing to see how that's changed really since January. So it's not for the faint of heart, but it can be done, or we've been able to achieve that for the most part. So great work on their part for sure.
Thank you. So Yiman?
Like, doing a hybrid program or, a virtual program, it's not easy because after all, it's a new technology. It's very double-edged. I mean, when I'm talking about double edge is that the participant can access the program a lot easier. I'm not even, hopefully they will have data and Wi-Fi to do that. But in terms of they don't have to rush around to pick up the kids. And especially in the winter time, they don't have to travel, in bad weathers, like these kind of things. But, on the other hand, we really have to look into policy in terms of like safety policy online, like things like that. We also, before the webinar start, we always let them know there is a ground rules. And one of them is, they are not allowed to take any pictures. I mean, whether they do it, we really don't know, but we always let them know you're not allowed to take photos. Because to ensure privacy and confidentiality, things like that.
Yeah, this is making me think a lot of things that could be interesting to circle back to and talk about as a network that I know that we did when the pandemic first hit and we were doing virtual and we were just needing to learn the basics of how to operate a Zoom meeting, but be interesting to have those conversations again and see what have we learned. And so I'm making definitely some notes for some future gatherings. So Iman, did you have more you want to say?
Oh, sorry. I didn't realize, sorry.
No worries. We are at 4:30 now, so I would like to, honor all of our time and wrap things up. But I want to check in with, was there any sort of last comment somebody was really hoping to make before we say goodbye? Really think this has been just a fantastic gathering, and I'm very appreciative of all of your time. Our guest speaker, Vani Jain, that was just a really great overview on some really in-depth research that's out there that we'll look for other ways to bring forward and for us to look into. And then also to our panelists, to Ellen, Iman and Maureen, for being willing to, put yourself out there in this discussion and, bringing forward such thoughtful responses. Really appreciated. Blanca as well, gratitude to you for co-hosting this event with us. And I hope you all found it to be a valuable experience. Is there anything you wanted to say, Blanca, as we are wrapping up?
Well, I also wanted to thank you, Sydney, because it wouldn't happen without you. All the logistics, thank you so much. The registrations, everything that goes behind. Thank you, Sydney. And thank everybody that's here today, and everybody that will see this recording at a different time. The work that you do is invaluable. You should know that. Don't underestimate your roles, because I have heard sometimes staff say, well, I just do a drop in, and you do so much more beyond that. So you are really the first responders, and families do respond to you and trust you. So your role is invaluable. And, you know, I can't say enough about the programs. We know we want to, you know, hopefully have more investments in these programs because they're so important. So we're working on that. And yes, thank you so much for another great celebration of your work and your role in maternal and child health, because we know that maternal health is directly linked to that early infant mental health. So we got to keep on keeping on. So thank you, everybody.
Keep on keeping on. Wonderful. Have a wonderful rest of the day, and we'll see you all again soon, hopefully.
Thank you.
Thank you. Bye-bye.